Yes, ma'am.
So started your timer and here is your question. Right. So if you have read and understood, considering the clinical examination statement, kindly begin.
Good morning. I'm Dr. Kuldi, one of the surgical candidate. May I confirm your name and date of birth, please?
Tom, 67 years old.
Today, hello, Mr. John. Today, I have asked to examine your right groin region, which include touching and looking and feeling and auscultating your groin region. Is it okay? We can proceed.
Okay. Are you going to ask
One,
for a chaperone?
yes, one of my staff member will be there throughout the examination, acting as a chaperone. Is it okay with you?
Yes, for your sport. Very good. Okay, yes. Go ahead.
Would you, Mr. John, would you take off your shorts, please? And can you stand for me?
Okay.
Now I will take the close look at the patient's groin region, and I will ask the patient to cuff for me, and I will check for the site. I will check for the size. I will check for the scar. I will check for the surface, and I will check for the visible cuff impulse. I will ask the patient to cuff for me. Then I will inspect the others. Now, first of all, I examine the right side. Now I examine the left side also for the same, for the size, site, shape, surface, as well as the cuff impulse. Would you cuff for me?
Okay.
Then I will look. I will check for the. Now I will go for the feel. Now I will proceed for the feel. Could you tell me? Do you have any pain at this moment?
No.
Can you reduce this swelling lump for me?
Yes.
Yeah.
Can only be
Now.
reduced by lying down. Yes.
Yes. Now I will check for the local temperature. I will check for the tenderness. I will check for the scrotal mass. I will check for the lymphadenopathy, and I will check. I will palpate the. I will palpate the lump, and I will again ask the patient to cuff for me, and I will check for the cuff impulse, and I will check for the consistency. I will check for the surface. I will check for the pulsatility. I will check for the compressibility, mobility, transillumination test, and I will check for the reducibility, and I will check for the relationship of the swelling in relation to pubic tubercle, as well as I will check for the relation in respect to inguinal region.
Yes. And also the size of the swelling itself.
Yes, ma'am.
Yes.
I will ask. I will check for whether it is going up to the scrotal region. I will check for the scrotal neck, and I will check for the scrotal skin also, and I will check for the scrotal mass also.
Okay. What else? Any other test that you'll do? Okay,
Ma'am, I will.
proceed.
Ma'am, I will auscultate the lump. I
Yes.
will check for the. I will auscultate the lump to look for any bruit or not, and
Yes.
I will do the
Not brewing, that sounds.
yeah, breath sound. Yes, ma'am.
Yes.
And I will palpate the. I will examine the abdomen of the patient to look for
And
any signs of intestinal obstruction, and I will
yes.
check for the chest examination to look, as a patient is a chronic smoker. I will need to see rule out the precipitating or predisposing factors, and I will check for the opposite side for the same, ma'am. to look for
Okay,
any
and
direct hernia. And I will check for the deep inguinal. I will check for superficial as well as deep inguinal ring, ma'am.
how would you do that? Explain the procedure.
Ma'am, through the 3-finger test,
Yes.
one I keep on one I
How
keep on
you
the
will
femoral.
extend the 3 fingers? Yes, please.
Ma'am, I thumb on the ma'am femoral ring, and in middle finger over the deep inguinal ring, and so superficial inguinal ring, and index finger on the this deep inguinal ring, ma'am, at the
Okay.
mid inguinal region, ma'am. And I will ask the patient to cuff. I will see at which finger I will feel the cuff impulse. If it
Yes.
is on the if it is on the index finger, it is a direct hernia. If it is on the middle finger, it is an indirect hernia. And if
Okay.
it is on the thumb, then it is a femoral hernia, ma'am.
Okay. What else would you be considering?
Ma'am,
You'll do the scrotal examination, so you'll feel for the scrotal neck, you'll feel
Yes,
if
ma'am.
the testes are separate or not, and then
Yes, ma'am.
also you'll do the DIR test, direct
Direct inguinal ring test, ma'am,
Yes.
to check for the relation of the lump in relation to the pubic tubercle, ma'am.
Yes, good. All
And
right.
I will check. Yes, ma'am.
Yes, and you'll repeat on the other side
At
as
the
well.
opposite side.
Yes. Then,
Ma'am,
once you are done, then
I will thanks the patient, and I will ask him to address
dress
himself.
up. Yes, or
Dress
you can
himself
assist.
and
Because
sorry,
patient is
ma'am.
60, or you can assist. You can
Yes,
offer
ma'am.
to assist because patient is
Yes, ma'am.
67 years old.
Yes, ma'am.
Right. Few seconds left, but then you would
To
have
complete my exam, ma'am, to complete
Yes.
my examination, I would like to perform the complete abdominal examination and the chest examination, ma'am.
Yes, good. All right. Well, we'll go and then start. Kindly begin presenting your case, please.
Today, I have examined a 67-year-old gentleman who
Yes.
presented with the right groin region swelling. He's a chronic smoker. On
Yes.
on inspection, there is a positive cuff impulse present in the right inguinal region, which is present in the inguinal region with visible cuff impulse. The other side is free. On palpation, it is non-tender, and it is medial to the pubic. It is medial to the pubic tubercle, and it is non-tender. It is not non-pulsatile and non-transluminant. Scrotal neck is full. On auscultation, there is no gurgling or bowel sounds. My main differential diagnosis is a right indirect inguinal hernia.
All right. So what are the differential diagnoses that you will consider for this patient?
Ma'am, I will keep a differential of a femoral hernia. I will keep a differential of the inguinal lymphadenopathy. I
Yes.
will keep the differential of a varicocele,
Yes.
epididymal cyst, lipoma of the cord, and testicular tumor, ma'am.
Very good. All right. What management can you offer to this patient to conclude?
Ma'am, I offer the patient, as it is a 67-year-old with a chronic smoker. I will offer him to abstinence from the smoking as well as inguinal
Lifestyle
hernia repair.
modification and
Lifestyle hernia repair, ma'am.
all right. What type of hernia repair would you recommend?
Ma'am, mesh hernia repair.
Mesh repair. Okay. That is if there is a hernia, but if it's something else, just suppose if it's hydrocele, then what management can you offer?
Ma'am, hydrocele repair, ma'am.
Yes, evacuation and inversion. All right. Okay. Right. But then if it is varicocele, how would you conclude, or how would you how would you confirm your diagnosis?
Ma'am, if it is a varicocele, ma'am, I need a ultrasound of the scrotum, ma'am. Along with, I will need a abdomen scan also to look for the cause of the varicocele, ma'am.
Very good. Okay. There was another, since it was on right side, how is it different if it would have been on the left side?
Ma'am, if it is the varicocele is on the left side, ma'am, it can be due to renal malignancy or testicular malignancy, because the left testicular vein is drained in the left renal vein, ma'am.
Very good. This is very important to know. Very good. Okay. Right. Anyone want to give feedback? Anyone wants to give feedback? It was good? Yes, please, Dr. Nancy. Yes, please. Yes, please. Yes, please. Good evening.
Yeah, good evening, ma'am.
Yes, please.
Hello.
Yes, please. Kindly give your feedback.
Okay, Fabian. Hello.
Yes, please.
Hello.
Yes, yes.
Okay,
Continue.
okay. All right, all right. All right, thank you very much. That was a nice one. You see the inguinal hernia, the indirect inguinal hernia is medial to the tubercle. I don't know. I don't know if that is really very correct. It should. Okay. Yeah. You are correct.
It is
Sorry.
correct.
Yes, you are correct. You are correct. Yes. Medial and medial and above. Correct. Then
Are you
the problem.
confusing with the epigastric artery, the vessel?
Yeah.
How
Don't
would
worry,
the
my mind.
relation differ? Yes. How would that differ? If the relation or the point was
If it
something
is, if it is the inferior epigastric hernia, it will move through the Hasselbalch triangle.
Yes.
So in that case, direct hernia will be medial to the inferior epigastric hernia, while indirect hernia will be lateral to it.
Yeah.
Yes, ma'am. Yeah. Is it right to mention other things before he came back to do the deep ring test? I felt he should have finished with everything concerning the groin before he goes to examine the chest and all that. He went to examine the chest and then came back to do a deep inguinal. Maybe he forgot.
Yes.
I don't know. Maybe.
Yeah, very good point.
Yeah.
Yes. Basically, yes. It shouldn't matter how you complete your examination as long as you complete it. But
Okay.
it's ethical that if not to bother the patient again and again, then it's ethical that you complete one examination, one part of the examination first before you move on to the next one. Yes, good point.
Okay.
Yes, please.
Yeah. Then finally, this 67-year-old man, in as much as he's a non-smoker, he may be having lower urinary tract symptoms. So a digital rectal examination should also be okay. And this, you will request to do a digital rectal examination also in this patient.
Yes.
I don't know if I'm making a point.
Yes. Okay.
Yes, ma'am. As in, you just maybe we'll mention, sir, I would also like to do a digital rectal examination to check for his prostate to be sure the prostate is not enlarged. That will causing him lower urinary tract symptoms that can make him to strain and he will have a hernia. I don't know if that is important in this exam.
Yes, quite important. Right, yes. Dr. Abbas or Dr. Nonso, whoever is first.
Yes, ma'am. Thank you very much,
Yes,
ma'am.
please.
Yes, I wanted to ask, ma'am, or just make a contribution. So when they were asking you what you were trying to assess other systems, I think it's also important to check the patient's urethra, especially external genitalia examination to assess the urethra, because one of the causes of hernia can be bladder or obstruction related from a urethral stricture. Besides that, you also want to do a genital rectal examination to check for the prostate, and also you want to assess for presence of a constricting rectal or rectal tumor, because you want to be sure that the patient doesn't have anything that would cause constipation or bladder outlet obstruction, because those are things that may predispose the patient to developing a hernia, aside the fact that lifestyle and other things, and then possible risk factors in the patient. Thank you.
Thank you. Yes, Dr. Duffer.
Yeah. Hello, everyone. I have two questions exactly. If we ask to examine a hydrocele, how we start? And during this, and the other question, if I examine the hydrocele, does that mean I examine the genitalia? And can I do the finger test, 3-finger test or 2-finger test to show it is reducible or not reducible? I know it is not reducible, but to show the examiner. Thank you for so much.
Second, we have the cell. Yes, Dr. Kuldeep, would you like to answer?
Yes.
Yes, please.
Like
That's
if it is a
another station. Yes.
like if it is a hydrocele, I can start my examination. Ki today I have asked to examine your genitalia, which include looking and feeling of your testicular area, and I will start my conversation like this. And in that, I will start again with the same. I will start the patient by looking and in standing position. Then I will proceed along with that. And in the same, because in the hydrocele also, if we look, we need to palpate, we need to see whether it is
Definitely.
continuous with the scrotum, with the inguinal region swelling or not. We need to palpate the neck of the scrotum.
Yes.
So I think it's better if we include both of the examination in that.
Together.
If we, yeah,
Yes.
if time permits, it's better to do that. If it doesn't permit, then we can conclude our statement by saying that if time permits, I can add the examination of inguinal region also.
Yes. And then the trans-elimination test as well. So
Yes.
Thank you very much. Yeah, thank you very
Ma'am,
much.
we can't carry this X-ray for the transillumination. This is just for saying, na?
just for
Or
saying.
and do we need to carry a stethoscope in the?
No,
I
no,
don't.
no, nothing.
No.
You don't need anything. Everything that you need will be provided in the station.
Okay.
Yes, Dr. Shahid.
Good evening, ma'am.
Good evening.
Ma'am, first of all, just to clarify that to differentiate between a hydrocele and an inguinal hernia, I think there is something called the get up of the swelling. We palpate the root of the scrotum. And as soon as after we look for tenderness and the rise in temperature, if the patient does not have any tenderness and there's no rise of temperature, the next test step we do is to get above the swelling, is to palpate at the neck of the scrotum. And once we get to know the neck of the scrotum, once we get above the swelling, we can comfortably rule out an inguinal hernia out of the picture. Bipinocele or complete inguinal hernia is completely ruled out because we have to get above the swelling. This was just to clarify the question which was asked before.
One more question. In adults, do they present with painful hydrocele? I'm not talking
very
about
unlikely.
Yes, heme hydrocele,
Very
not symmetrical, not including. I don't think, because it's in adults, it's mostly secondary, and it's painless.
Right, ma'am. So usually this is what was told to us while taking our clinical examinations, that once you get above the swelling, it's a completely scrotal swelling, and there is no question of an inguinal hernia coming into the picture at all.
True.
Second, ma'am, in the examination, is it okay if we just mention I would like to also proceed with the digital rectal examination to look for the prostatomegaly?
You can say, to complete my examination, I would consider doing this, because considering the age of the patient and to rule out blah, blah, blah. So at the end, you will not be doing it, please. Don't do it, but mention it at the end.
Right. Ma'am, once we come to a clinical diagnosis of inguinal hernia, it is a definite clinical diagnosis of inguinal hernia. If the examiner asks us, do you have any other differential diagnosis to give?
The ones, we know that yes, Dr. Kuldeep gave, they are the reasonable, because for inguinal hernia, you'll have an original, not an actor, but a real patient. If patients are there, there will be a patient with the hernia. Yes.
Ma'am, is it okay to give any other differential diagnosis other than inguinal hernia? Because inguinal hernia is a definite clinical diagnosis.
If you are asked for, listen to the question very, very carefully. If you are asked for provisional diagnosis, then your first provisional diagnosis in this age and with this history should be inguinal hernia. But if you are asked differential diagnosis, then you can mention lymphadenopathy, varicocele.
Right.
Many, yes.
Right.
Even the femoral hernia.
So.
Yes.
Right.
Then you have to mention others, because then they are challenging you. They want to know how many different conditions in this region are you aware of.
Right. Sure. Thank you.
And then they may ask you to differentiate one from the other. Like I asked him, how would you confirm that it's varicocele? How would you, if it was hydrocele, how would the management differ? Or what management would you offer then? So that's how they'll ask one or two questions, and they'll realize how much knowledge you have or how much you have memorized. They get to know.
Sure.
They know.
Yes. Right. Thank you.
Someone else, Dr. Fabian, I think he raised his hand.
Yes. I raised my hand.
Yes, please.
Yeah. This question was on inguinal hernia. So the point the last speaker was saying, I don't know if it really will come to play in this clinical scenario. Your question was very specific on inguinal hernia. So going to rule out Hydrocele to check the root of the scrotum and to check whether the mass is separable from the testis, which is characteristic of a hernia, and whether it is not separable from the testis, which is the characteristic of Hydrocele, may not come to play here because the mass is just at the groin, it's not in the scrotum.
No.
So you may not need that step. You will just waste your time doing that step.
You won't even have this much time. And besides, after 6 minutes, you hardly get 2 minutes and you have to present your case and answer. Differential diagnosis, management and treatment, or investigation and treatment. So hardly you'll get that much time for this much chit chat. Yes, Dr. Abbas. Yes, please.
Thank you, ma'am. Thank you, ma'am. I think Dr. Mohammed was responding to Dr. Dafa's question. It wasn't actually, yeah.
Yes, maybe, yes. All right. Thank you, everyone. Dr. Kuldeep, my one
Yes,
most important query or the feedback is that, okay, you entered the room, you presented yourself, you confirmed the ID of the patient, and since it's the COVID era going on, if there is any spirit or anything, wash your hands.
Oh, sorry, ma'am. I forgot. Sorry.
Yes, and you won't be wearing gloves because you have to feel for the temperature of the patient. So
yes, ma'am.
No gloves. So that's why washing hands and at the end as well, because it's examination station. You touch the patient at the end when you're thanking the patient and asking the patient to dress up. You'll just wash your hands again at the same time without wasting your time or anything. Just this much, little bit.
Yes, ma'am.
Yes, Dr. Dafa. It can be important considering the season, Yes, Dr.
Yes, ma'am.
Sorry for that, but my friend, I said my story with my friend. My friend removed the gloves to check the temperature, and the examiner shouting, "Why do that?"
Yes.
Because he said it is better to feel the temperature without the gloves. He said, I don't know, but he said that for me. He said, no, we are in COVID. We shouldn't remove your gloves.
Yes, but
this is what's happening.
Don't put them on from the beginning. This is my request, because otherwise, how could you feel the lump, the swelling, the temperature? Feeling cannot go ahead without with the gloves on. So don't put them on. Yeah.
Okay.
Thank you. Started, and here is your question. Right, so if you have read and understood, considering the history-taking station, kindly begin.
Hello.
Hello.
Good morning. I'm Dr. Ilmun Kabir. How have you been feeling recently?
Actually, I don't want to speak.
Very good. To anyone.
In the past days, during your hospital visits, for the 4th time, we found that you are feeling depressed and hopeless, and you don't much show interest to talk, or you don't just expressing that you are feeling tired. Is that the reasons, Mr.?
Yeah. I feel I'm not good. Feel I'm low mood. Yeah.
Oh, are you comfortable with me to talk for and to ask some questions?
Yes, go on.
Talk for a little while.
Okay.
Yes.
Okay, talk for a little while. So, did you feel that your sleep pattern been changed recently?
Yes,
Like,
actually, yeah.
yeah, do you feel that you are feeling difficulty to get up or going to the sleep?
Actually, I went when I went to sleep. I take time to sleep, and in the morning I'm difficult to get up early, so I all time I get up later.
Okay, so are there any particular times of the day you feel that your mood is worse?
Yes, it is afternoon.
Okay, so do you find that it gradually worsens throughout the day or it only in the afternoon?
Yes, in the morning when I wake up later. I take my breakfast sometime. I'm walking, but it's gradually I become feel low mood, and especially when the sun sets, so I feel it's so bad. Yeah.
So, and also have you noticed that you have change in your appetite? Like you, before you eat breakfast, your lunch at this particular time of the day, but now it's changed. Did you feel any change at that
Yes,
moment?
yes. I feel it's decreased now. Yeah.
Typically, what did you eat in a typical day right now?
I take my breakfast, cheese, and my cup of tea, and then break rice and some soup. In the night, sandwich. But now I didn't eat. Just take one in the morning, coffee, a cup of tea, or yeah, cup of tea, and in the night I just take sandwich. Yeah.
Okay, it doesn't sound healthy. So I want to ask you a personal question, if you don't mind. Do you
Yes.
feel
Good.
that a change in your libido, like you don't notice a difference in your sex drive?
Actually, yes. I
Okay,
feel that, yeah.
so have you felt ever have you ever felt like this before?
At this, I have one episode before 6 months, yeah.
Okay. Have you ever feel that to harm yourself or others? Like by checking your history, I saw that you accidentally takes extra doses of routine medicines.
Yes, I took that because I feel I need to sleep. I need not to go to outside, yeah.
Do you want to harm to anybody? Do you feel like that?
No.
Okay. In the past, have you had any problems with your mental health?
Actually, as I said, I have one episode before 6 months, yeah.
Okay. So have you had any counseling for any issues before?
I contacted the council one time before, yeah. They give me advice, yeah.
How many months before that is?
It's after 5 months or 6 months, yeah.
For that reason, do you have to admit in the hospital?
Yeah. After that, I
Okay.
attend the counseling, yeah.
Okay. Did they say anything regarding this and what is the result?
I don't know. They told me you have low mood and give me medication and give me some advice.
Okay. So thank you, Mr. For your kind cooperations, and We will
Good.
here to help you in every possible way and get back to us if you need
Can you
anything
present
and
your
any
case
kind of
now?
help. Yes, Mr. Smith, 67 years old, here presented with us with referred by the GP because of taking extra medicines and repeatedly talking with low moods and confused. After taking his history, I found that he is depressed and showing no interest in any kind of work, and he also feeling so tired to talk with me, and he said that he didn't get to bed in the right time, and when he wake up and he didn't get back to the sleep early, and he said that his moods change in the afternoon and become worse throughout the day, and he is not taking his breakfast or any
What
foods
management
regularly.
options
And
can you suggest for him?
so to me is that a moderate to severe case, because after taking his history, so I will advise him to do some regular exercise.
Yes.
And to maintain some sleep hygiene.
Yes.
Then I want to prescribe him some selective serotonin reuptake inhibitor drugs.
Yes.
And some high intense psychological interventions, and
For example,
like
cognitive behavioral therapy.
Cognitive behavioral therapy,
Interpersonal therapy. Yes. Anything else?
interpersonal therapy, then immediate and considerable high risk to themselves or others.
Yes.
And maybe I will advise him to admit to a psychiatric ward as soon as possible.
Very good. And would you, according to which law? Mental Health Act. That admission that you're recommending,
Is
according to Mental Health Act. Very good. All right.
Yes.
She thanked and she introduced herself, and she started off. Didn't confirm patient's name and age. Patient was not willing to, was not willing to communicate in this one. And her strategy to convince the patient was polite and respectful, and the way she requested the patient to talk, because patient is admitted patient, she can confirm it with the journal. And in the real scenario, please try to make sure that you are looking at the patient's arm and you confirm the patient's ID. Right, it is very reasonable and logical what your friend said that you didn't confirm it. Otherwise, I think it is extremely important, like extremely improved history taking. You covered everything and within given time and throughout the way, you were calm, you were trying to, you successfully engage the patient in conversation. This is very important.
Okay.
So good.
Okay,
Very
thank
good.
you, ma'am.
Keep it up. I'm really happy. Anyone else, if I've missed anything, they can tell you. They can give you feedback. Yes, Dr. Dufford, how did you feel in this scenario?
Yeah, she's good communicated. She responds
Yes.
very well for
Yes.
my concern, and she respects that, and she tried to make me more comfortable, reassures me, but she need more with the. I said I'm very bad. I'm very I feeling very bad. You should in the way of the history, in the middle of the history, she should respond to this. You should respond. I'm sorry to hear that. We try to help you, but
Yes.
overall she's very brilliant, and she summarized everything. Yeah.
Yes, yes. This one point is also very important, Dr. Ilmon. In during history taking, you have to show empathy. If patient in the middle says, I'm feeling very bad, say, I'm really sorry to hear that. Like in an appropriate way, yes.
Okay,
yes.
ma'am.
Very good.
Thank you.
I also I can say in the history there are 4 points for the communication. So you should sit in the end of the chair and keep eye-to-eye contact and give the some word, it is the assurance. It is very important because 4 point, it is not it's too easy to get it.
Two examiners will be
Okay.
there. One examining your knowledge and other examining your gestures and unspoken language. Good.
Okay. Thank you.
Started your timer. Here is your question. Right. So if you have read and understood, considering this surgical anatomy station, kindly please tell me what are the bones you're looking at in A, B, and C? What
A
is
is
this one,
the
please?
left posterior surface of the posterior aspect of the left scapula.
Yes,
B is the anterior aspect.
yes.
And C is the bones of the upper limb, showing the
Okay.
scapula, clavicle, humerus, radius ulna, and the bones of the wrist and the hands.
All right. Okay. If you just focus on, I'm sorry, picture C, on this area on my cursor, can you tell me what type of joint is formed with the humerus, scapula, and the clavicle?
It is a ball and socket type of synovial joint.
What is the name of the joint?
Shoulder joint.
Yes. What are the movements which are possible at this joint?
In the shoulder joint, the movements are flexion, extension, abduction, adduction, internal rotation, external rotation, and circumduction.
Okay. Can you please identify these parts? What is 2, please, in picture A?
This is the acromion process.
Okay. And what is 3, please?
Coracoid process.
All right. Can you please tell me the surface marking of coracoid process?
It lies at the medial 3/4 and lateral 1/4 of the clavicle, and 1 centimeter below that point.
Very good. All right. Can you please tell me the names of few structures which are attached to the coracoid process?
Yes, coracoid process, it gives origin to the short head of biceps and the coracobrachialis, and it gives insertion to the pectoralis minor muscle.
Anything else?
And yes, and there are ligaments.
Yes.
The coracoclavicular ligament, coracoacromion ligament, and coracohumeral ligament.
Yes. 3 ligaments and 1 insertion and 2 origin of 2 muscles.
Two origins.
Yes, very good. Okay. Can you please tell me what are the muscles which strengthen the shoulder joint?
The main muscles are the rotator cuff muscles.
Yes, please.
They are the supraspinatus, infraspinatus, teres minor, and the subscapularis.
Can you please tell me their origin, insertion, and nerve supply of all of these muscles?
Yes, the supraspinatus originates from the supraspinous fossa, and infraspinatus from the infraspinous fossa.
Yes.
And the supraspinatus, infraspinatus, they are inserted into the greater tubercle of the humerus.
Yes.
And teres minor, it originates from the outer surface of the medial border, upper part of the medial border, and also inserted in the greater tubercle.
Yes.
And subscapularis, it originates from the subscapular fossa and is inserted into the lesser tubercle. The nerve supply to the supraspinatus and infraspinatus is by suprascapular nerve, which comes from the upper trunk, the brachial plexus, and to the teres minor is by axillary nerve, and to subscapular by upper and lower subscapular nerve.
Very good. Okay, what are the factors which decrease the stability of the shoulder joint?
It is the shallow glenoid cavity,
And
the lax ligaments, and also due to the presence of quadrangular space on the inferior aspect of the joint,
Right.
which makes it weak.
can you please tell me, can you please tell me the boundary of the quadrangular space?
Yes, quadrangular space, it is bounded above by the teres minor, inferiorly by teres major, laterally by the surgical neck of the humerus, and medially by the long head of the triceps.
Very good. And the contents?
And the contents are the axillary nerve and the posterior circumflex humeral vessels.
All right, very good. Can you please tell me what are the muscles which are inserted in bicipital groove?
Yes, in the lateral lip, it is pectoralis major. In the floor, it is the latissimus dorsi, and the medial lip, it is the teres major.
Yes, good. Okay, can you please tell me about the axillary artery, from where it begins and how many parts it
Yes,
has?
axillary artery, it is a continuation of the subclavian artery from the outer border of the first rib, and it ends at the lower border of the teres major muscle, which continues as brachial artery. It is divided into three parts by the pectoralis minor muscle.
Yes.
And there are branches. From the first part comes the superior thoracic, from the second part the thoracoacromial and lateral thoracic, and from the third part by the subscapular and the anterior and posterior circumflex humeral arteries.
Right. Okay, can you please help me and read this image? What are you looking at, please?
This is the MRI of the shoulder joint.
Yes.
Showing one is the acromion process.
One is, yes, and two.
Acromion process. 4 is the clavicle. 6 is the glenoid cavity.
Yes.
7 is the labrum.
Yes.
5 is the deltoid. 10 is the supraspinatus tendon. 9 is the muscle. 8 is the head of the humerus. 2 is the 3 is the axillary recess, and 2 is the axillary nerve and vessels. The posterior circumflex vessels.
All right. Can you please tell me the origin and insertion of biceps muscle?
Yes, the biceps muscle has 2 heads. The long head originates from the supraglenoid tubercle, and the short head from the coracoid process, and it is inserted into the radial tuberosity of the radial bone.
What is the nerve supply of biceps muscle?
It is supplied by the musculocutaneous nerve.
Yes. Okay. Can you please tell me at what points can you check the reflexes of the upper limb?
Yes, there are mainly three reflexes: the biceps, triceps, and the supinator. Biceps, we check on the biceps tendon in the cubital fossa, and triceps, we check on the triceps tendon by flexing the elbow 90 degree.
Yes.
And the supinator we see around 4 centimeters proximal to the base of the thumb on the radial side.
What are the root values that will
for biceps is C5, C6, and for the triceps C7, C8, and for the supinator C6.
C7. Yes.
C7 and C6 for supinator.
Yes. Okay. Can you please tell me? You've already told me actually. Yes. What is the motor and sensory supply of the axillary nerve?
Yes, ma'am.
Axillary nerve, motor and sensory supply of the axillary nerve.
The axillary nerve supplies the deltoid muscle and the teres minor muscle.
Yes, and the injury to axillary nerve is presented by what?
Axillary nerve, it presents as failure of abduction.
Yes, over 15 degree.
From 15 to 90 degree.
Yes.
And also there is loss of sensation on the badge area.
Very good.
on the
Okay,
shoulder.
that's good. Right. I basically have asked you everything. Very good. Thank you. Started the timer, and here is your question. Right. So if you have read and understood, considering this critical care scenario, kindly tell me how would you manage this patient now?
Okay, I will manage according to the CRISP protocol using ABCD approach. Check the
Yes.
airway.
Yes.
Patient can speak. I will move to the breathing. I will check,
Yes.
inspect for any wound. I will count respiratory rate. I will inspect for any chest movement asymmetrically. Then I
Yes.
will palpate for the trachea.
Yes.
On tracheal deviation, I will palpate for the chest expansion and movement, looking for any asymmetrically. Then I will do percussion. Then I will auscultate. Then I will move to the circulation, check blood pressure and pulse rate.
All right. What is the provisional diagnosis that you're considering?
This patient most likely have pneumothorax.
What are the types of pneumothorax that you are aware of?
There is open and closed pneumothorax and simple and tension pneumothorax.
Right. How would you differentiate between tension pneumothorax and simple pneumothorax?
In simple pneumothorax, there is tachypneic, tachycardic, and hypoxia. There is no cardiovascular compromise, while in tension there is cardiovascular compromise and high JVB, low GCS, and low blood pressure. Also, there is tracheal deviation. And
Right. So what is the urgent management that is required when it comes to tension pneumothorax?
For tension, there is thoracostomy, second intercostal
Yes.
space in the mid-clavicular line.
All right. According to the NICE guidelines, how should you insert it? What is the technique of insertion of central venous line, considering the NICE guidelines?
I will do set it onto ultrasound guiding.
Yes.
Then do just X-ray.
How should the position of the
cornea.
patient be?
There will be Trendelenburg position, head down.
Yes.
I will palpate for the two head of the sternocleidomastoid and the median end of the clavicle at the center of this triangle. I will insert the needle at the level of 30 degrees downward towards the ipsilateral nipple.
Yes.
Then I will aspirate for the blood. Then I will insert the Seldinger, which is a guide where the blood is aspirated.
All right.
After that, I will suture with silk.
Suture the line with silk. Okay. How would you confirm afterwards? What would you do?
I'll do chest X-ray.
Yes.
For the any suspected of pneumothorax, for the tip of the catheter at the end of superior vena cava.
All right. Okay. What is the surface marking of inferior internal jugular vein?
Ear lobule, medial lateral to the carotid pulse.
Medial end of the clavicle. Okay. Right. How should or what techniques do you know to remove this central line?
Patient head should be down to prevent any air on, please.
Okay, what are the indications when you should remove it?
Sending patient home and improvement of the acute condition. Also, if there is line sepsis,
Okay,
and
right.
in stop any cardiac intraop support.
Resolution. Okay, right. If there is, like you said, if there is a sepsis, what is the most common organism that you will suspect?
This is most likely have Staphylococcus epidermidis.
Right. Can you tell me if there are any ways you can prevent the central line infection from happening on the first place?
I will insert using preparation aseptic technique, hand
Yes.
wash or
Yes.
hand rub with alcohol. Then I will wait until the agent is dry.
Yes.
Then I will
And
use the 5 sterile precaution, sterile gloves and sterile drape, and use cap and mask and sterile gown. Also, we can use the central line maintenance. Wash your hand with soap or alcohol before and after touching the line. And
alcohol,
remove
not
it as
alcohol, alcohol-based hand rubs.
alcohol-based hand rub.
Yes.
I'll also remove it as soon as longer no needed.
Very good. Can you help me and read this image? What are you looking at?
Okay, this is just examples to anterior view. The trachea is deviated to the right.
Yes.
And there is no bone discontinuity. There is no cardiomegaly. There is the absence of costophrenic angle on the left side.
Yes.
Most likely. There is no gastric bubbles. And there is shifting of the mediastinum to the right. This most likely have tension pneumothorax.
Very good. Okay. And what these arrows are pointing at?
This is called the visceral line of the pleura.
Okay. Just suppose you've inserted the central venous line, and if you don't remove it, what are the complications that can occur?
Can lead to sepsis and infection.
And
Also can lead to rupture of the red atrium, can lead to cardiac tamponade and arrhythmia. And also there's arterial puncture, can lead to hemothorax or pneumothorax.
all right.
And
Anything else?
pseudoaneurysm.
Okay. When reading this imaging, what is exactly all the things that you should look for? What
I
this
will
ABCD mnemonic stands for?
A for the airway, look for the trachea, and B for the look for any consolidation or any lesion. Or
Yes.
then I will see for the cardio. I will look for the heart shape and the mediastinum. D for the diaphragm. I will look for the costophrenic angle, any elevation of the diaphragm. Then I will look for the lung equal field. Then for the gastric bubble and the hilum.
All right. When inserting central venous line, what is the highest point you can insert into internal jugular vein?
At the level of the thyroid cartilage.
Okay. You already told me. Okay, investigations. What are the investigations that you'll do immediately when you've inserted the line and the patient started sudden patient has sudden onset of breathing? So what are the investigations that you'll ask for?
Ask for just X-ray, bleeding profile, and microbiology lab.
Chest X-ray and ABGs. Right.
ABG.
Good. Thank you.
Thank you.
Yes. This is good. Everyone is started the timer, and here is your question. Oops, I'm sorry. Yes. Right. So if you have read and understood, considering the communication skills patient, kindly begin.
Hello, I'm Dr. Judge, one of the surgical residents in Royal College Hospital. Please, I'm calling for advice on a patient that had a cholecystectomy 4 days ago. I would like to speak with the consultant, the hepatobiliary consultant. May I confirm who I'm speaking with, please?
Okay, yes, you're speaking with Dr. Mann, the hepatobiliary consultant in Queen's Hospital, London.
Thank you, Dr. Mann. I'm calling on behalf of a 45-year-old female who ab initio as well had a cholecystectomy 4 days ago, and today she started complaining of abdominal pain, which is worsening, and also complaining of nausea and tachycardia. Complaining of nausea, no vomiting yet though. We also, following that, we noticed some things in her drain, like a bile in her abdominal drain. We requested for an abdominal ultrasound scan, which showed a free fluid in her abdomen. Other investigations that were done, the total leukocyte count was at 18. The C-reactive protein was at 50, and also the bilirubin was noted to be high. With all these findings, we thought she is having a bowel leakage post cholecystectomy. That is why we are calling to get your advice and also possibly transfer for experts management.
Okay, doctor, thank you very much for the summary of the case. What are the possible causes of leakage in this patient? You did cholecystectomy 4 days ago, you said. What could be the possible causes of leakage, doctor?
Possibly, it could arise from a cystic stump, the cystic duct stump leakage. There may have been a slip in the clip, and also it could be injury to the common bile duct or from the liver bed where the gallbladder was, or also from accessory injury to accessory cystic duct or aberrant right hepatic duct. Injury to any of these structures or slip leakage or slip clips could lead to this leakage.
Okay. You did a laparoscopic cholecystectomy?
Yes, a laparoscopic cholecystectomy was done.
Okay, that's fine. So how are you managing the patient now? What is the patient on?
Currently, we commenced our management using the CRIPS protocol. We assess the airway, the breathing, the circulation, for which we have started intravenous fluids, and also the patient has been started on intravenous antibiotics. Other investigations we would have loved to do would have been ERCP, but currently our facility is not functioning.
Okay. How is the abdomen of the patient? Is there any, did you examine the abdomen?
Yes, examining the abdomen, there is generalized tenderness. However, there are no features suggestive of peritonitis, such as guarding or bowel-like rigidity.
Okay. So why the call for referral? What do you want really at the moment?
All right. Bearing in mind that this is a hepatobiliary injury, we would like your specialist advice and also management. Also, we are worried that there could be development of biliary peritonitis, which we wouldn't like to occur in this patient.
Okay. Did you insert a drain during the surgery?
Yes, there was a drain in the bed around the area of. Yes, there was a drain inserted.
Okay. So, what is the color of the drainage right now?
Currently, we have a gold-colored exudate, which we think is a bile.
Okay. So, do you think it's urgent at the moment to send him across to me? At this time, you're calling me.
I think it is so that a delay could lead to development of biliary peritonitis. I understand for the adequate or definitive management because of the inflammation in the area that may not be done immediately. We may have to wait for about 6 weeks for a proper or definitive management. But for now, for the fear of the biliary peritonitis, I think she would need some urgent attention.
Okay. Do you have a magnetic resonance pancreatography scan there in your hospital?
We do, but at the moment, it's not functioning.
Okay, no problem. The patient may need MRCP and ERCP. Okay, but
Yes.
before we move on, do you need to? Where is the patient at the moment? Right now, ICU or where? Where?
No, the patient has been in the HDU unit.
Okay, all right, no problem. So, who are you going to involve? Any arrangements? Anything you need to?
Well, so far I'll need to reach out to the bed managers of both hospitals to see how we could arrange for a bed space for her so that she wouldn't have any issue when being transferred. If there's no space, possibly they could arrange for a discharge or possibly transfer between both hospitals, repatriation of some of the patients to the other hospital, to our hospital, to afford bed space for the transfer.
Okay, no problem. Doctor, make sure the patient is stable and if possible, transfer the patient to me with an ambulance with assisted by a nurse. Is that okay?
That will be fine by us, sir.
All right. Thank you.
Thank you, sir.
All right.
What more you could
Yes,
have asked?
Mr. Man.
Still there is 1 minute.
Yes.
If no beds are
Summarize.
available, if no beds are available, then at the hospital at the moment, then how would you proceed? What would you do?
We would still speak with the bed managers to see if
Yes.
they could facilitate any discharge or have an arrangement between both hospitals to repatriate some patients and create a bed space for the patients.
Okay.
Yes, ma'am.
Right, he has just asked you, but can you tell me what is biliary peritonitis? What is biliary peritonitis?
Okay, biliary peritonitis is an inflammation of the biliary peritonitis is the inflammation of the peritoneum and content of the peritoneal cavity as a result of bile accumulation or bile spillage or bile contamination of the peritoneal cavity.
Okay, can you tell the difference between ERCP and MRCP and how is it done?
Okay, MRCP, they are both imaging modalities used in assessing the biliary hepatobiliary tract. The MRCP makes use of the magnetic resonance imaging to show this. For the ERCP, that's endoscopic retrograde cholangiopancreatography. This makes use of X-ray imaging, whereby an endoscope is passed through from the mouth into the duodenum and from the sphincter of Oddi. Contrast or dye is being injected to outline the hepatobiliary tract. And when the X-ray is taken, it affords the opportunity for these tracts to be outlined. If there is any obstruction from a stone, this could be seen, or if there is any spillage, this could also, the points could also be seen with the X-ray. Yes, ma'am.
Broadly, what is the difference between these two modalities?
One is non-invasive. The other would require the use of an endoscope.
But then ERCP is therapeutic as well as.
Okay, yes, ma'am.
Yes,
ERCP is both diagnostic and therapeutic.
Yes.
Because stenting could be done,
Yes.
stones could be retrieved, or sphincterotomy could be
Yes.
done, which may not be achieved by MRCP.
Very good. This is the answer I wanted. Very good.
Yes,
Okay.
ma'am.
Thank you.
Okay.
So, question. Right. So if you have read and understood, considering the history taking station, kindly begin.
Good evening. I'm Dr. Kuli, one of the surgical candidate. May I know your name and age, date of birth, please?
Age.
Okay. Mr. Frank, I'm 33 years old.
Good.
Hello, Mr. Frank. I am here to discuss. I am here to ask you some few questions regarding your condition. How can I help you?
Okay. I have this problem with the right side of my groin. I noticed the swelling there for about 8 months. 8 months now,
Okay.
and currently it's becoming more painful.
Sorry to hear about that. Do I offer you some painkiller? Or do you want me to do something, or shall I proceed?
No, you can proceed. I think I should be able to cope with it.
Okay, thank you. Can you tell me how it started? It started suddenly or it started gradually?
It started gradually.
Okay. Is it present only on the right side, or it is present on the left side also?
No, it's only on the right side.
Okay. When you notice it for the first time?
I noticed it for the first time. That was 8 months ago in the gym while doing some of
Okay.
my exercises in the gym. Yes.
Okay. Sir, do you have noticed any factors which increase the swelling or which decrease the swelling?
Sometimes if I'm in the gym doing some of my exercises, it could come up. And I notice sometimes if I'm trying to urinate, I find it difficult urinating, so I have to strain. And while straining, it comes out also. But normally when I lie down, it just goes down on its own before initially. Yes.
Sir, have you noticed any change recently in the swelling, in the size?
Yes, it has gone a little bit bigger, and recently I can't push it back easily without so much pain. Recently, if I try pushing it back, it comes with so much pain.
Sir, do you have any tummy pain along with that, or do you have any sign and symptom of any vomiting during this recent change in your swelling?
No, the pain is just around there. There is no vomiting.
Sir, is there any pain around the swelling?
Yes, just yes, there is just mild pain.
Sir, can you point towards which side of the pain is there, and can you describe the character of the pain? Is it sharp? Is it throbbing, or it is shooting type of pain?
Well, the pain is just around the swelling. Sometimes it comes up so hard as if it's gripping me, and then sometimes it relaxes, and after a while it comes again.
Sir, it is traveling somewhere else to your tummy or to your leg or to your private portion?
No, it's just around there.
Okay. So have you noticed anything which increases your pain or which helps to get better?
Nothing much really increases it. When it happens like that, I just lie down for some time. After a while, it will go down on its own.
So do you feel any hotness or any redness around the swelling?
No.
Do you feel any, do you have noticed any discharge from that swelling, or any, do you have any fever or anything?
No, there is no discharge from the swelling, and there is no fever too.
Sir, do you visit your GP frequently, sir?
Yes, once in a while I do.
For can I ask you for what condition, sir?
Just some routine checkups. Nothing. Okay, initially I had I had a discharge when urinating, something yellowish before when urinating. So I had to see him for that. He gave me some medications for that, and that had stopped. So from time to time, I still see him to evaluate that.
Can you let me know what type of medicine that was, if you know?
It was just some drugs for the discharge. I can't recall the name. When urinating, then I used to see some discharge.
Okay, sir, no
But taking
problem,
the
sir.
drugs, it had stopped. Yes.
Sir, do you have any drug allergy?
No, I don't.
So may I ask you some personal questions, if it is okay
Yes,
with you?
please.
Do you
Okay.
are you married or unmarried?
Yes, I'm married.
Okay, so whom with you live?
I am married.
Okay, with
I
whom you live?
I live with my wife.
Do you smoke, and do you smoke cigarette, or do you take alcohol?
I don't smoke cigarette, but I take alcohol just once in a while, not always.
Okay, okay. Sir, do you have any recent travel history? Do you visited any country recently or any place recently?
No. I have not traveled out recently.
Sir, I have seen in your charts you had a history of taking a stamina tonic. Can you let me know what is the content of that tonic? Is it containing steroid?
Yes, it does. It's just things that helps me with my exercises.
Okay,
Right.
Mr.
Can you
Frank.
present your case now?
Sir, I have taken a history from
Yes, doctor.
Yeah, I have taken a history of 33-year-old male who is a
Yes.
gym trainer who presented with a gradual onset of 8-month duration right-sided groin swelling, which
Yes.
was which was increased while standing or while doing straining, but it was initially reduced on lying down. But now patient presented with a change in while reducing. Patient presented with a pain while reducing it, and patient also had the history of steroid. Patient also had the history of stamina tonic, which contains steroid, and patient also gave the history suggestive of some urinary tract infection in the past.
Right. So how do you intend to manage this patient?
I will.
Yes.
I will need to work up the patient for in view of abdominal. I will need to examine the patient. I will need to examine the inguinal scrotal swelling. I need to examine the patient abdominal examination and order some lab investigations along with some radiology.
Right. And then what management options can you offer to the patient?
If it is not reducing and it is painful, I need to give the patient option of surgery, in which I need to go for hernia repair.
Right. How long would you wait, or would you try conservative management before you'll offer the patient surgery?
Ma'am, as this patient is presenting with increased pain while reducing it, I'm suspecting some already advanced stage, so I will not offer him a conservative treatment. I will start directly offer him a surgery.
Right. So time has ended. Right. How many things have you missed in your history?
Ma'am, I missed ICE,
And?
idea, concern, and main
Patient's
ICE.
past history of your genital tract. You forgot to ask patient about the visits to GUM clinic. What is GUM clinic?
Ma'am, I have heard for the first time. Sorry.
Yes, but these are the clinics which are used in England. So tell me.
Ma'am, I have no idea.
Tell me what that is. So this history was very important that you should have taken.
Okay,
Then when I asked you to present your history or your case, then you should have told me, when you told me the detailed history that you had taken, then you should have told me that if time would have allowed you, I would have taken the history of ICE and the history of GUM, and then you didn't take, because patient told you it has become painful now. So you could have asked the scale from 0 to 10, how much
Yes,
is the
ma'am.
scale, what is, so that you have also missed.
Yes, ma'am.
Right, patient, you asked the social history kind of, that if you're married or not. So what else was important? Because history of trauma, maybe if patient had any injury or acquired any injury, because patient is a gym trainer, So once they are working in the gym or training someone, they can themselves get injured as well. So that was also important. Right. And when I asked you how would you go ahead and manage the patient, you told me about the examination. At that time as well, you could have said you'll do the complete history, you'll take the complete or detailed history. If not complete, you could have used the word detailed history. And you'll take the history of patients' GUM visits, GUM clinic visits. These are the genitourinary
Medicine clinics.
conditions. Yes, condition. That's why they go there. So how many times patient has presented there, what is the cause, etc. So that is the, and then you can tell me about the examination and investigations and etc.
Okay, ma'am.
Right. And treatment, yes. So treatment will you. Okay, started the timer and here is your question. Right. So if you have read and understood, considering which history taking station, can we begin?
Okay. Good evening. I'm Dr. Kolade. I'm one of the surgical doctors here. Can I know your name and age, please? Hello.
Tom, 64 years old. Yes, continue.
Okay. All right. I want to ask about what brought you to the hospital today. Hope it's okay by you.
Yes.
Okay. All right.
It's
You've been
Kuldeep,
bleeding.
you're helping.
Yes, go ahead. Sorry, ma'am. Actually, I was on mute. Sorry. Okay, go ahead.
Yeah. You've been bleeding from your back pass for how long now, sir?
Yeah, it is present for last 6 months.
Okay. This blood, is it always bright or is dark in color?
No, it is bright.
Bright. Okay. What's the volume?
Sorry.
Volume of blood that comes, and how many per day you use to pass the blood?
Initially, it is around a small teaspoon. Now it is around a bowl.
Hello?
Yes.
Hello. Initially, it was around teaspoon. Now it is around a couple of ball.
Oh, sorry about that. Is there the bleeding? Do you feel dizzy after an episode of bleeding or not?
Yeah, doctor, I am feeling so much of dizzy while I'm passing stool. I'm feeling very much dizzy.
Do you have pain with passage of the blood or not?
Initially, there was no pain, but now, doctor, I'm feeling pain while passing stool.
The pain is in your back part or is in your tummy?
Doctor, I have a pain in my tummy too.
Where specifically in your tummy?
Doctor, it was present. Doctor, it was present. Doctor, it was present in the lower part and towards the left, slightly towards the left side.
Sorry about that. Could I give you analgesics now or you are okay?
No, doctor, I can bear it. You can go ahead.
You are having difficulty in passing, you are constipated. For how long have you noticed it now?
Doctor, I was constipated for last 2 days.
Yeah, sorry. You are losing weight. Since when did you notice that you are losing weight, sir?
Doctor, I have recently lost 10 pounds of weight.
Your appetite, how is your appetite? How about your appetite?
I am not interested in eating any food. I lost my appetite recently.
The do you your physics when it's your stool when it comes out, is there discharge there? Do you notice any discharge there?
Yeah, doctor. Actually, it is present. Sometimes the fresh blood passes with the stool. Sometimes it is present without the stool. I'm literally upset with the condition.
Sorry about that. Do you have pains in your joints, swelling in your joints, or problems with your eyes?
No, doctor. I don't have any issue with that.
Do you have fever, sir?
No, doctor. I don't have any fever.
You travel of recently to any place
No,
before
doctor.
coming back in the last
No,
maybe
doctor.
last 1 year?
No,
You've
doctor.
not.
I haven't visited anybody recently.
What was your idea about this pain?
Doctor, I'm thinking I am suffering from serious illness, which is leading to this fresh blood, and I'm constipated for last 2 days.
Okay, sir. Sorry about that. Do you have any concern? What was your concern about this?
Doctor, I'm very much concerned about my loss of appetite as well as the recent weight loss, 10 pound of weight loss.
Sorry about that. Then your expectation, what was your expectation?
Doctor, I want a cure from you. I want a diagnosis from you.
Right. Do you have apart from your hypertension, you've been hypertensive since how long now? Then which drug are you using?
I'm taking Dr. Torvas, and I'm taking some medication for last 35 years.
Okay. Then you smoke also?
Yeah,
how
doctor.
long?
Doctor, I smoke a pack a day for last 35 years.
Do you drink alcohol?
Occasionally, I take drinks.
Any jaundice? Do you have jaundice, vomiting?
No, doctor, I don't have anything.
And no cough at any time, and no chest pain?
No, doctor, I don't have any chest pain. I don't have any cough.
Any urinary problem?
No, doctor, I don't have any urinary issues.
Any swelling in your tummy?
No, doctor, I just have a pain while passing stool or while passing blood. I have a pain in my tummy, which I already told you, which was present in the lower side and was slightly towards the left side.
Yes, social history. Who lives at home with you?
I didn't hear you,
Doctor,
ma.
I recently divorced, doctor. I am living alone.
What is your occupation?
Doctor, I was an engineer, now retired. Retired.
Okay, thank you. Can you present your case now?
Okay, ma. And I've interacted with a 64-year-old male.
Yes.
That presented with 6 months history of passage of bright red blood from the rectum with associated abdominal pain in the left lower part of quadrant of his abdomen, with associated constipation with weight loss and anorexia. He's a known smoker of 35 years and known hypertensive, controlled on medications.
So what are the differential diagnoses that you would consider for this patient?
Okay, ma. My differential diagnosis will include colon cancer,
yes.
Also diverticulitis, which is also another differential diagnosis, and also inflammatory bowel disease.
Okay, and maybe hemorrhoid. Okay, can you please tell me what are the most important investigations that you'll carry out for this patient?
Okay, ma. I'll do a colonoscopy, yes, plus or minus biopsy.
Anything else?
Then the other test I want to do also abdominopelvic ultrasound or CT abdomen for him. Also full blood count to know his state of to know his PCV, which may be low because of the bleeding paritum that he has, and then electrolyte, urea, and creatinine, because he may have electrolyte derangement because of the bleeding, and then the
All right. Any other investigation? Maybe microbiology of stool culture?
okay. Then
Why
stool,
would
I
that
also
be?
want to do
Yes.
stool microscopy culture and sensitivity.
Yes. All right. In fact, in this age, there could be many conditions. So there is one investigation from mesenteric angiography that can also be used to localize angiodysplasia or Meckel's diverticulum. Right, then common blood for hematology, arterial blood gases as well, because there could be a fear of metabolic acidosis. Patient did complain that patient feels dizzy and not well. Okay, these are the investigations. We couldn't ask about the management, but then can you please tell me what were the things that you have missed? You
What
did
are the
ask
things that?
you have missed in history taking?
Okay, the things I think I missed asking him about
Family history.
itching and swelling around his back pass.
You kind of covered that, but the most important thing was the family history, because if you think inflammatory bowel disease, then that doesn't happen.
Yes,
First you
for the
have the
inflammatory
history.
bowel disease, I asked him if he has joint swelling, joint pains,
So if anyone else in his family has the same condition.
and then I also asked about problem with his eyes, so which he
Yes.
said he doesn't have.
Yes, but you didn't ask if anyone else in his family had the same condition. So family history to rule out was important.
Skin problems also. I
Yes.
didn't ask about it.
Yes, good. Otherwise, it was good. You covered, you asked confidently, and you covered everything. So good. And here is your question. Right. So if you have read and understood, considering it surgical pathology patient, kindly tell me what you understand by the term or by the condition sickle cell disease.
Yes, ma'am. Sickle cell disease is a hemoglobinopathy that results as occurs as a result of abnormal replacement of glutamate with valine and the position 6 of the globin gene, resulting in conversion of a normally soluble hemoglobin protein, the globin protein, to an insoluble form, which contains the valine amino acid. This subsequently results in abnormal precipitation of hemoglobin within the red blood cell during periods of low oxygen tension. Yes. And the patient eventually develops, the red blood cells then eventually develops abnormal form from the initial disc-shaped red blood cell. It may develop an abnormal spherical shape, which and also reduced pliability within the blood vessel, then subsequently resulting in hemolysis or clumping within the vessel and subsequent hemolysis.
What are the risk factors which lead to this sickling, or this sickling is precipitated by what? Can you mention?
Yes, ma'am. In following periods of low oxygen tension, like acute illness, like fever, upper respiratory tract infection, gastroenteritis, periods of decreased fluid, diarrhea, that's decreased fluid, intravenous fluids, that may result in stasis within the blood vessel, and also low oxygen tension because of chest infections that may result in hypoxia, which may result in low oxygen tension.
Can
also
you
trauma.
mention some acute complications that can result because of this condition?
Yes, ma'am. They may develop acute sequestration crisis. They may also have acute hemolytic crisis. They may develop vaso-occlusive crisis. Patients may also develop severe visceral sequestration crisis. They may develop stroke, avascular necrosis, recurrent infection, especially skin, sickle cell ulcers, some of the complications, and acute chest syndrome is another complication.
Okay, can you please tell me why it is relevant surgically?
Yes, ma'am.
Relevant. Yes.
Yes, ma'am. Sickle cell may be relevant surgically, as sickle cell may be a cause of surgically relevant conditions that may be amenable to surgery, or a sickle cell patient may present with conditions that may require him to have, that may not be directly associated with a sickle cell, but may require him to have surgical interventions, and as such will require adequate management. For the conditions that a sickle cell, that may be as a result of the sickle cell anemia, this includes development of gallstones. The patient may also have autosplenectomy. Patient may also have development of acute visceral sequestration crisis, which may, especially in the spleen, which may necessitate splenectomy. Patient may also have acute cerebral syndrome, which may require neurosurgical intervention. Acute chest syndrome may also be one of the complications. Avascular necrosis may require a hernia arthroplasty, and then ulcer may require plastic surgery review.
Okay, the patient may require blood transfusion. So how much, what is the limit of hemoglobin that we should keep in our mind?
Yes, ma'am. Depends on the steady state hemoglobin concentration of the patient. That is the level at which the normal hemoglobin level of the patient at its steady state. But in preoperative patients, one wants to achieve a hemoglobin level of greater than 10 grams per DL. In order to and also have adequate hydration.
Why is it important to keep in your mind about the use of tourniquets in patients with sickle cell anemia?
Ma'am, you said what?
What is the importance of keeping in your mind using the tourniquets with for when it comes to the patients with sickle cell disease?
Yes, ma'am. It's preferable to avoid tourniquet if it is except when absolutely necessary, because in patients with sickle cell anemia, because of the stasis of because of the fact that tourniquet may induce an hypoxic state within the limb, and also because of the stasis and sluggish flow that it may be induced within the limb because of the tourniquet that may be tied on the limb, that is tied on the limb. This may result in sickling and hemolysis within the region where the tourniquet is tied, and subsequently may result in acute crisis, development of crisis with patient.
All right, okay. Can you please tell me why patients with sickle cell disease are immunocompromised and how it leads to autosplenectomy?
Okay, ma'am. In patients with sickle cell anemia, yes, some of the causes of immunosuppression is that the fact that the spleen, which is a major immunological organ, is usually functionally defective. That is because of the autosplenectomy. And then and the autosplenectomy, for the subsequent question, the autosplenectomy is a condition that occurs in older aged sickle cell anemic patients or young adults, where because of the recurrent stasis within the vessel, this will result in multiple infarction as the patient ages, and then subsequently develops fibrosis within some parts of the spleen, and then subsequently the spleen continues to shrink, and the areas of viable splenic tissue continues to decrease because of the recurrent infections as the patient ages. And subsequently, the spleen will shrink, and then splenectomy develops.
Yes, thank you. In this case, a patient was brought to the hospital after hit and run. So
yes,
he was unconscious. That was accidental finding of a mass in temporal region through CT scan. So how do you interfere? What should be the management of this patient?
Yes, ma'am. Following initial resuscitation of the patient, following the ATLS protocol, and then following the initial resuscitation, patient, the mass should be assessed using a contrast enhanced CT scan to confirm, to be sure whether it is a hematoma or a brain tumor. If it is a brain tumor, the patient will be managed. Will be managed using.
What are the most common primary brain tumors which are found in elderly people?
The commonest primary brain tumors in elderly people is their gliomas, especially the grade 4 glioma, the WHO grade 4 gliomas, that's the glioblastoma multiforme. Also, they may also present with medulloblastoma, although that's more common in the posterior cranial fossa. They may also have meningiomas. They may have pituitary tumor or cellular region, supracellular region, cellular supracellular tumors. They may also have craniopharyngiomas, second peak.
Since this patient is unconscious, we don't know, but considering the location of the mass or the tumor in the temporal region, how would this patient or this mass would have manifested?
Hello, ma'am.
Yes, please. Considering the condition, the location, yes, please. Considering the location of the tumor, how would you tell me that how would the tumor will manifest? What would be the manifestation of
hello, ma'am?
Tumor? Can anyone else hear me?
Ma'am, I can hear you.
Yes.
It can be, ma'am, because it is in the
Yes, please. No, Dr. Abbas, can you hear us?
As it is involving the temporal lobe, ma'am, it can present with the hearing loss. It can present with the herniation.
Hello, ma'am.
It can present.
Yes, please.
It can present.
Okay. Sorry. The patient's history. Patient can present with a history of considering it's in the temporal lobe, history of forgetfulness, amnesia, recurrent seizures. The patients may present with features suggestive of hypothalamic dysfunction, considering the closeness of the temporal lobe to the hypothalamus. Patient may also, if it extends to neighboring structures within the, speech problems, also may be affected. They may also have effects on the midbrain, may also be compressed, considering the relationship. That's the tectum of the midbrain, considering the relationship of the temporal lobe to the tectum and to the midbrain. And also, patient may have visual problems too, especially because of the fibers of the optic tract that may pass along that region. Then the other presentation may be features of raised intracranial pressure with that the patient may present with.
I'm not sure all the manifestations that you are telling me are for temporal lobe. You are kind of mixing as well. We were hearing from Dr. Kuldeep, I think. Can you also add, please?
Okay.
Yes, ma'am. Ma'am, patient is presenting with the temporal lobe involvement, the patient can present with the emotional disturbances. Patient can present with the hearing loss. Patient can present with the herniation, which can lead to palsies of the nerves. It can present with the diplopia. It can present with the double vision, or it can present with some mood disorders because of the involvement of the amygdala and all.
All right. Good.
Cognitive impairment.
Yes. All right. Okay, that's thanks. Very good. Okay, thank you.
Thank you, ma'am.
Thank you, both of you. Dr. Abbas, it was very good. Very thoroughly you have prepared.